have another wonderful panel you're about to hear from about emergency services, clinical services, rural and city. But before we get into the panel, just want to remind all of you that please continue to take a lot of notes, ask a lot of questions, but there are mics on both sides here. At the end of the panel, if you would come to the mics up front so everyone can hear, because there's so many important things that are being brought up. We want everyone to actually hear those questions as well as the responses. This group up here, you have a bio in your handout. They are a very distinguished group. We have Harry Findley from UAB. Harry, in the Birmingham area, orchestrates so much of the psychiatric services for the Birmingham area associated with UAB. And we have Patricia Moore, who's out in the field in the rural area and runs a community mental health center, Western Mental Health. She's presented some things earlier that I think that you're going to be very interested in, and how you can develop some connections between the cities, rural areas, and then Miss Jackie, Dr. Jackie Feldman. I asked each one of them what they wanted me to present about them, and her statement was, "Here's Jackie." So, here's Jackie.
I am short, but I'm mighty. When Jimmy asked me to talk about this, I of course jumped on it because I'm a hysteric and I love to talk. I do want to pledge to each and every one of you, I am a ferocious advocate. I will come and speak to whomever you want me to speak for free. I will travel for free. I will cross the entire state of Alabama if you want me to talk to your city council, to your church group, to your temple, to your legislature, to your classrooms, to your NAMI group. I will come and talk for free. I'll pay for my travel. I will come. I will be there because that's what we need to do. We all need to make a commitment to change, a commitment to this process. So I'm going to put myself in the line. I'm retired. I can do whatever I want. It's so nice being retired, except I don't feel retired. But that's okay, because for me, retirement, I've told several people this today, means I get to say yes to what I want to do and no to that which I don't. But I'm saying yes to you all. I'm easy to get a hold of. You can Google me. My email is there. I will respond immediately. So please use me as a resource. But we're going to talk about the Mental Health Summit. The time is now. Well, the time was now last year. The time really is now this year. After the set of speakers who spoke about their lived experience, I went to Jimmy and said, let's just stop now. What more else is there to say? Because those are the profound statements that we should carry with us when we try to go and talk with people who are in charge of making the decisions, who are in charge of funding. Those lived experiences are really the most powerful things we can share with people. But when I was trying to come up with a metaphor, I like graphics and stuff, I thought, well, this is like a puzzle, and we need to put the puzzle together. And I don't know how to move this forward. Can someone move it forward for me? Thank you. I'm an academic, so I always have to talk about objectives, just because you're getting CMEs or education credits for this. But I want us to talk about what are the barriers to excellent care. I'm going to talk about, oops, you need to go back one. Oh, you know what? This is for my talk this afternoon. I have a different slide set. So we may need to discontinue this and go to the other one. This is part one that I'm speaking to. But anyway, I'm going to talk about the objectives. I'm going to talk about are what's the status quo right now for care, for emergency rooms, and for inpatient care. Then I'm going to talk about some best practices that I think have developed around the state. I'm going to introduce you to the vernacular, a series of words that are called sequential intercept model. Now, people who are in criminal justice understand that, but I think it's applicable to mental health as well. Then I'm going to talk about emergency rooms, inpatient care, and how we transition to community care. And Harry's going to help me. Thank you, Harry. Okay, the sequential intercept system, are we there yet? Are we changing it out? Is somebody helping me? Wanda, are you helping me get to the different one? All right. The sequential intercept model really was explained early this morning by James Tucker, who talked about Judge Johnson's 300-page decree, which is actually very interesting reading. You should all read it. But the judge has identified within the context of the Department of Corrections that there are areas that need to be addressed because there are challenges and there are points in the line of clinical care where things are falling apart. The same thing occurs within the context of someone who is living with mental illness and the family members around them. You need to be able to identify when someone is having a problem. They need to have access to treatment. If they need treatment in a more restricted fashion, they need to have a hospital bed available. They need to be able to be treated by trained staff. And interestingly enough, and I agree with this, we should work really hard not to segregate people simply because they're a vulnerable population, but instead what we should do is step up and help them not be so vulnerable. All right, so if you think about the sequential intercept, the trajectory of somebody's life, when does somebody first get touched by the mental health system or the criminal justice system? Somebody's going to show up and they're going to have a behavioral problem. They may be loud, they may be violent, they may be agitated, they may be uncontrollable. So, as talked about in the lived experience this morning, somebody talked about, well, they picked up the phone and they called the sheriff's department who came and picked them up. The question becomes, do they go to jail or do they go to the emergency room? I'm not going to talk about the jail, but let's talk about the emergency room. If you go to an emergency room that has psychiatric support, meaning a psychiatrist on site, which is very, very rare, it can still take hours. It can take hours to even get a room. You will get evaluated, but let's say you need to have more intense care and you need a hospital bed. There may or may not be a local hospital bed. In the UAB emergency room, which is, as far as I'm concerned, the gold standard of care, we have people who unfortunately get boarded for 3 or 4 days before we can find a bed for them. And I'm telling you, someone who is agitated and psychotic or manic, being in an emergency room is hardly the place you want them to be. If you're in an emergency room without psychiatric supports, that's a whole nother world, because oftentimes that's the quick slide to get admission. Nobody can step in, nobody knows quite what to do, nobody knows quite how to evaluate, and or people may be subject to more chemical or physical restraint because people don't know what to do. The other thing that we talked about from people who talked about lived experiences this morning was that wonderful reenactment of a CIT interaction and how the officer said, don't lay hands on somebody because you don't know what they've experienced. Somebody goes to an emergency room and they're grossly agitated and are unable to calm down, hands will be laid, and it can be a terribly frightening, traumatic experience. So you have to remember, people are going to have that memory and may have PTSD from that situation. But let's say they need inpatient stabilization. Are there beds? Sometimes you may have to transfer to another hospital, and I talked about that experience. But if beds exist and they're open, then the patient can be admitted. But you have to understand, change doesn't happen like that. If somebody comes in with a heart attack and they go to the ICU, they're not discharged 18 hours later. It takes time for people to get stable. Now, if somebody comes in and they've broken up with their boyfriend and they're suicidal, sometimes things can change overnight. Somebody comes in and they have a blood alcohol level of 340 and they're suicidal when they're intoxicated and they sober up, then those people can stabilize quickly. But a huge number of people come into the emergency room needing inpatient treatment, and it takes more than 2 days for people to get stabilized. So that's a message out to anybody here who's an insurance provider. Sorry, I have fought many battles. So let's say they're in the hospital, We have got them stabilized. Now we want to transition them to community care. The questions you need to ask is, how soon can we get the patient an inpatient or an outpatient appointment? And will it be with a psychiatrist who can write a prescription? You know, giving somebody 3 days prescriptions when you come out of jail is great, but not when they go to a mental health center where they're seen by somebody who doesn't have an MD or an NP behind their name, and then they don't get prescriptions. So how do we deal with that? That's a workforce development issue I'll talk about later this afternoon. Can they get their medications? I tell my residents, don't write a prescription if you don't ask how they're going to pay for it, because it's useless, as you just throw it in the trash. And if they can pay for it, let's say they've got $3 or $6 or $4 for Walmart, cigarettes, medication. You know, it's a hard, and we're talking about an addiction. That's a hard decision for some people to make. So maybe we need to give them the medication or find out a way to do that. Do they have transportation? Do they have a place to stay? As far as I'm concerned, no care can occur unless you have a roof over your head. Housing first concept is very important. Do they have a job? Do they have a way to make money? Do they have other supports? Do they need help accessing entitlements? Do they need to have someone to help them kind of broker their services? All those are questions that should be asked when we're transitioning people to the community. So the time is now. The time is now for change. We need CIT training, so at the very beginning of that sequential intercept process, we can intercept right there. I think we should consider centralized urgent care 24/7 services that is welcoming, that uses peer specialists, that has 23-hour stabilization, that starts treatment immediately and doesn't let people sit in the emergency room grossly psychotic. We need to have accessible substance abuse services and emergency housing. We need to have trained crisis staff with adequate mental health supports. We need to coordinate access to beds and not do this kind of willy-nilly thing. And we need to ensure follow-up appointments. So, last slide. Need for collaborative planning across the spectrum. We need to stop pointing fingers. Well, they're not doing it, and I can't do it, and I don't have the money, and this is all my money, and I need all this money so I can take care of my people. We're all taking care of each other's people. So I would suggest that we lower the silos and all start to work together. I think services should be patient-centered. What do the patients want? Frankly, and I've told this story before, when I ask my patients what they want, they don't say, I want the voices to go away. They say, I'd like to have a date on Saturday night. And I said this last year, me too. So we need to ask our patients, what do you want, and how can I help you get there? We need to be creative about how we provide our services, and we need to keep working to bust stigma. I say to you that somebody comes into the emergency room who is who's grossly psychotic and agitated is just like the person who's coming in with a heart attack, but they're having a brain attack. We don't send people out to the waiting room to wait for 12 hours when they're having a heart attack. We should not do that to people who are having a brain attack. Thank you.
So, Jackie, you're a tough act to follow. I've had to follow you a few times for the last almost 20 years, so bear with me. I'm not quite as entertaining as Jackie, but I'll do my best. I'm Harry Findley. I'm the executive director of the UAB Community Psychiatry Program. It's also known as CPP. We're one of the mental health centers in the Birmingham area. It's divided up into 3 mental health center areas. JBS is sort of the parent of all of us. We contract with JBS. We cover the sort of central I-65 corridor area for Birmingham. And JBS also provides outpatient services like the other mental health centers, but JBS, unlike the other mental health centers, provides all of the case management array of other services in the residential services. We don't do residential, we don't do case management. If you could, the next slide. So, yeah, you can sit to the next slide, that's fine. That's CPP. We occupy the 4th floor of that building. We're on the UAB campus. We're unique in that we're embedded in the Department of Psychiatry in an academic school of medicine at UAB. I don't know how many other mental health centers are like that in the country, maybe 8 or so, Jackie's saying. So it's a pretty unique relationship that we have. We train residents. We have 8 fourth-year residents, and, or excuse me, 8 third-year residents and about 3 fourth-year residents that rotate with us. We train medical students. We train master's level social work students, as well as some nurses from time to time. Let's see, so most of the services that we provide are in this building. You can go to the next slide. Other than this building, this is right up the street where our Ingalls School is, and that's the location of our child and adolescent day treatment program. You can go to the next slide. Our outpatient clinic services, we have evaluations. Like Jackie was saying, you come in for an evaluation at CPP, you always will see a psychiatrist or a nurse practitioner that same day of the evaluation. If prescriptions are necessary, you'll walk out with prescriptions. With an appointment for return for that, for a provider and maybe a therapist or some other services that you might need. We can provide psych evals, neuropsychological evaluations with a neuropsychologist. We have a psychopharmacology clinic with psychiatrists, nurse practitioners that's also staffed by psych nurses and psychiatric social workers. We have psychotherapy services, groups, individual therapy, family therapy. All of those are done by our licensed independent clinical social workers. You can go to the next slide. We offer day treatment services, both intensive day treatment and supportive day treatment. The intensive day treatment program has a psychiatrist that's attached to that program that sees the patients at least once a month, monitors their progress, and provides medications for them. Both of those day treatment programs also offer GED classes. You can go to the next slide. Let's see, Ingalls School it's comprised of 3 different programs. That's the Child and Adolescent Day Treatment Program, therapeutic preschool program, and the summer program. Most of the students that are in that school come from Jefferson County. We have a collaboration with Jefferson County that provides some of the teaching for that school, although we do contract with other neighboring school systems. You can go to the next slide. Oh, so the REACT program. This is sort of my baby. Years ago when Jackie hired me at CPP, REACT was just sort of a research project for us. The state didn't have any assertive community treatment programs, and we got in on sort of the ground floor with a lot of help from NAMI, from Greg Carlson, who's back there in the back. Lots of other people made that happen, and we started the very first assertive community treatment program in Alabama that's still up and running. There's a difference between ACT and PACT in Alabama, and as far as I know, there are only 2 PACT programs. There's the JBS PROACT program, which started around that same time, and the REACT program. These are the most intensive outpatient programs available. They're heavily staffed with lots of psychiatrist time, lots of professional social workers, as well as nurses. The services are available 24 hours a day, 7 days a week, 365 days a year. It's been known as the hospital without walls, and pretty much will do whatever it takes to help people live independently in the community. We also have a collaboration with JBS to provide sort of supportive services for some of the folks in the REACT program for the housing grant that JBS has. So that's permanent supportive housing. There's 50 units of that. We also utilize the Jefferson County Housing Authority as well as the Birmingham Housing Authority to help people live independently in their own apartments. Next slide. These are some other things that are important to talk about. Unfortunately, DMH no longer has the IDP program or the indigent drug program, but we have our own person we employ to work with drug companies and our patient assistant programs that they offer. Most of the time we can help people that don't have insurance coverage come up with some sort of medication that works for them. Let's see, appointments and access. We always see state hospital discharges within 72 hours, not just because we're contractually obligated, but because it's the right thing to do. We see local hospital discharges from UAB within 7 days. Again, not just because we're contractually obligated. Our new patient appointments, right now we run about a month out, although we have special arrangements with like the mental health court that Jonathan was talking about, as well as some other entities that we can get people in sooner that are a much more vulnerable sort of population that needs to be seen before that 1 month time. One more slide. Our follow-up appointments, unfortunately, we don't do as well with this as I'd like to, and it's because we don't have the resources to follow up with people that miss appointments. We do phone calls. We have staff that does a great job of calling people and locating them, but I don't have a lot of ability to go out into the community and track people down. We refer people to JBS that have missed their appointment. If they're a state hospital discharge, JBS does a great job of helping those people get back in for their next appointment. But sometimes our folks tend to fall through the cracks and we're not able to find them. REACT is pretty full and can't go out into the community and do that sort of thing. Transportation is another barrier. We don't provide transportation services other than within the REACT program. But we do work with Medicaid non-emergency transportation services as well as public transportation. We work with probate court and Michelle. We do outpatient commitments. We accept pretty much all of them they send our way. That's a probably underutilized thing that we could do more of. Let's see. We sometimes assist family members just to help them get in touch with Michelle and probate court and talk to them about what the process might be. Encourage them to file petitions when we feel like that's the thing to do and send them your way. Next. So that's it for me. I want to make sure that we have time for Patricia to talk about your rural mental health center as opposed to an urban mental health center. And we'll save the questions for last.
Hi. I'm Patricia Moore, Executive Director of West Alabama Mental Health Center. We are a rural community mental health center on the west side of the state of Alabama, covering 5 counties. Those counties are Choctaw, Greene, Hale, Marengo, and Sumter counties. We've been around for a while, and we're basically the provider of behavioral health services in those 5 counties. And when we're talking about crisis and ongoing services, we try to address as many issues as possible during the regular business hours. We do outpatient. We have outpatient offices in all 5 counties. When we think about services and set up services to address the needs of our individuals that we support and serve, we look at it as being by county. And that is, one reason is because it is a large geographic area to cover. So therefore, travel time, we don't want most of our time to be travel time. We want most of our time to be time spent with the individuals that we serve. So we have our offices in each county. Basically, we have about 14 locations for all services provided in the 5 counties. On the mental illness side, we have outpatient services. We have a rehabilitative day program in 2 counties. And we have some residential beds, 10 beds in the specialized behavioral home. We also have about 22 supportive apartment beds, and we have 16-bed specialized medical home that is in Moundville. That was our most recent home that is open. When we were told that Bryce Hospital was downsizing, it kind of alarmed us for a minute because we knew that we used Bryce Hospital for a lot of placements. And if that was not going to be available for those individuals under commitment, then we needed to make sure that we had additional services set up in the community in order to serve those individuals. And if we're it, then we need to have it set up so that we can provide the services that we need to provide. We do have crisis and emergency services after hours and weekends. That is something that we have maintained continuously. We have master's level clinicians who are assigned to emergency services for after hours and weekend face-to-face contacts as needed. As long as the individuals that are in crisis, we do have the requirement that they go to the hospital emergency room, or if they're arrested and go to jail, that we will go there to see them. But it's basically in the hospital and in the jails where our clinicians can go see. We have regular outpatient services, like I said, on an ongoing basis. We do respond to face-to-face after hours when it's determined that that is needed. And we were, when we received and started working on the Bryce Census Reduction Project, we started collaborating with our hospitals, and we actually presented to each of our hospitals in each county that to see if they would establish a adult psychiatric bed unit. At that time, we had no adult psychiatric beds in our 5-county area in West Alabama. So we had memorandums of understanding with hospitals as far away as Birmingham, with Hillcrest, and we sent some individuals in, if they were under commitment or acute care, to DCH North Harbor. And that was it for us. We also had an agreement, because we're so close to the Mississippi line, we had an agreement with Alliance Mental Health Center there in Meridian for commitment services. Just so happened, Brian Whitfield Memorial Hospital, after some convincing and explaining to them about acute care and commitment process in a community mental health center, they did open a 10-bed adult psychiatric unit in Demopolis. So we collaborate with them in regard to getting individuals in to acute care hospitalization services as soon as possible. We do have an access to care process where we have a single point of contact for individuals requesting services. That access to care point is also encouraged to be used by law enforcement and other providers and other individuals and individuals themselves to access services. So it's a 1-800 number, and it goes into our access to care department, which is manned, and when someone calls in, they should get someone on the phone to talk with them about services. We try to get people in, individuals in at the next available appointment. So therefore, the wait is minimized for those services. So for them coming in. One area of improvement that we do need in regard to our access and in regard to our emergency services and crisis response is we don't have a clinician available for each county. We only have one person on call for 5 counties. And that is impeding us keeping the clinicians on staff, because a lot of the clinicians now don't want to do emergency services. They don't want to be called after hours. They want to do their job and don't want to do emergency services. So we are having to address that issue in regard to our staffing. We do have a court liaison and a crisis therapist that is on staff that responds to the probate court and law enforcement and individuals who are in jail to help them access services as soon as possible, and hopefully have them spend as least amount of time as possible in the jail. We have always been innovative and accepting of services to be coming to our area. Most of the times, and people know at the Department of Mental Health, when there's an offering for new services, we always try to figure out a way to get some of the services that is being offered. But that is because we want to be available for individuals who need those services. And one of the areas most people ask about when it comes to rural mental health services is doctor time, having a psychiatrist available. And we have worked hard to do that. We do not have a full-time psychiatrist. We have a consultant psychiatrist, but we also do telepsychiatry, and we have those services available. Our consultant psychiatrist, she also delivers services through our telepsychiatry connection, and we have contracted with another psychiatrist to provide those services for our individuals. So we address that issue and that need for services in the Community Mental Health Center. We try to be available, we try to be responsive to the community, and we try to make sure that individuals receive services that they need. And so therefore we are responsive based on that. Having our law enforcement trained and working with the law enforcement, we do training with our Demopolis Police Department, but we would love to have the opportunity to train with all of our law enforcement departments across our 5-county catchment area, because they come in contact with the individuals, and if they have to go into the hospital and bring them to the ER, most of the time that transportation is provided by law enforcement or family members. And transporting someone in crisis, we want both the family and the law enforcement to have as much information as possible in how to treat those individuals with respect and dignity and get them to services. It's a pleasure to be with you today, and we thank you for this opportunity.
We have some questions, Tom.
Solved all of them.
Can she expand? Oh, I'm sorry.
Can you expound a little bit on your telepsychiatry program? Yes, ma'am.
For some time now, we received a grant, and we were actually an FCC pilot project. We also was a part of a grant with the Bristol-Myers Squibb Foundation, who actually provided our first units for telepsychiatry. What that does is that if a psychiatrist is in, say in Montgomery, and they're licensed in the state of Alabama, we can contract with them and provide telepsychiatry in Demopolis or whatever our locations are. And the psychiatrist can see the individuals through the telepsychiatry equipment, through telemedicine. Yes. And we have to do that. We tried to recruit a psychiatrist to Choctaw County, and we could not get a psychiatrist to go to Choctaw County, so that brought up the availability of psychiatric services in Choctaw County is entirely through telepsychiatry services.
I think the development of telepsychiatry is one of the most innovative technologies that's happened in the last 10 years in psychiatry. And I would certainly suggest that as a group, as a community, we'd be thinking about how we can use telepsychiatry in emergency rooms. There have been plenty of studies that have shown that other states have been able to massively improve access and quick evaluations for people who are living with mental health problems Even if the ER itself does not have a psychiatrist, they can access one through telepsychiatry, and it's proved to be budget helpful, because what you can do is sometimes you can prevent hospitalizations and really enhance crisis stabilization if you have that telepsychiatry capacity.
Dr. Feldman, how many individuals do you need in order to be invited to come and speak, like to maybe a NAMI group with / staff and or consumers?
One,
That's terrific.
my email address is real easy. It's jfeldman@uab.edu. And that's the one that I check most frequently, so I'm happy to come and do it.
Jackie, I don't know what equipment y'all invested in the UAB system, but something that we have available in our office is a system called Zoom. I don't understand it at all. That's what IT does. But it's so efficient that you can download an app on a cell phone, and the receiving end can see you and talk with you over the cell phone. It's unbelievably efficient. I've done depositions that way, and hiring and firing and that sort of stuff. And so there are ways to do it.
There are absolutely ways to do it. I'm on the credentials committee
That don't cost that much money.
at UAB, and we just accepted, and UAB is a ponderous, bureaucratic, lovely place to work, but we just accepted the regulations and have developed the regulation and accepted them in terms of understanding that telemedicine is here to stay, and it's incredibly effective and useful. And as the months and years pass, the technology costs are going way down. One of the challenges we had at the UAB Mental Health Center, because we actually tried to do this, several years ago, and it really was not successful, was trying to negotiate with other mental health centers in terms of credentialing issues. But I think those are surmountable, and I think whatever leeway can be granted and whatever progress we can make would be incredibly helpful, because we have residents at UAB who I bet would love to moonlight doing this kind of thing. So there are efficiencies that we could put into a system, and I think we could be providing better, certainly emergency crisis intervention care with telemedicine.
Thank you for your work. It's just some great stuff that's going on. But for people like Mark and, I have a son in Taylor Hardin Hospital right now. Can you talk about the connection between Taylor Hardin Hospital, where the work is so good? It's just remarkable where my son is at this point. It's just absolutely remarkable. But can you talk about how closely you work as the safety net, and what is the communication between the community mental health center and the psychiatry and the psychology at Taylor Hardin to make sure this thing stays on track and is truly successful on down the road? I know there's a lot of variables, but what can we expect? What is the connection there, if you could?
I can speak a little to it. I think what you're underscoring is that there continues to be a disconnect. And typically people they are not sent from mental health centers to Taylor Hardin. They have to be incarcerated within the context of a city or a county, probably a county jail system, because they're there for potential felonies. And they are then referred to Taylor Hardin for an evaluation and treatment if they're found not guilty by reason of insanity, or they can spend time at Bryce as well. So when they are released, they're typically not released to the community. They're released back to wherever they were incarcerated, and then they're followed up at the mental health center. So I think that disconnect is what's happening, is we've got really good care, I think, at Taylor Hardin and at Bryce, and they get sent back, and I don't know how much time they spend within the local incarceration before they are then discharged. I think we can certainly, we do need to work on firming up that connection, and how can we ensure that once they go back to the local place of incarceration, they continue to get treatment, and that once they're discharged, they are seen quickly. Now, I worked as a federal court monitor for Tutwiler for 5 years under it was a different federal case. Alabama is the make-me state. Nothing happens without a federal court decree. But one of my suggestions at that time, and it was many commissioners ago, which was, how about if we work with the Department of Corrections? Because like UAB Mental Health Center has a fiduciary contractual obligation to see people discharged from Bryce within 72 hours. Not 3 work days, but 72 hours. Why, as a sister agencies, why can't DOC and Department of Mental Health work together and say, not only does that if somebody who's coming out of the Department of Corrections should be seen within 72 hours if they need mental health care. Why don't we do that? Why don't we make that a contractual fiduciary obligation, just like we have to see somebody out of Bryce? So that's my one suggestion to the Department of Mental Health and Department of Corrections. They're sister agencies. We're all working for the same thing. We don't want somebody coming out of Bryce to relapse. We don't want somebody coming out of the Department of Corrections to relapse. It saves money to take care of people quickly, to get them engaged in systems of care. So I would just suggest that's something we do.
Hello? In the involuntary commitment area, there are some probate judges who require a psychiatrist present in court to make these things go through. Is there any movement on the state basis to amend the state laws to allow telepsychiatry to be used in this context?
Not that I've heard of, and I think that's a great suggestion. We're fortunate in Jefferson County that our judges come to the hospital. Thank goodness, because I can't imagine any psychiatrist, getting up and going down to the court. And I think use of telepsychiatry, or even by phone, is a really excellent idea. And I think that's something that we should work on.